3. My guess is that this is probably going to be under this chapter. Okay. Let me open up the other side of things as well. Okay. Starting from the top. Vascular distensibility. Let me see real quick if this is PowerPoint has all this info in it, or if it's going to be hiding another PowerPoint. That one. Oh, here we go. Here we go. Okay. We'll take a look and see kind of what similarities we have side to side. Comparing Dr. Tate's material to previous material. Okay. Vascular distensibility and functions of the arterial and venous systems. So learning objectives, I like the other PowerPoints in my notes just because they have the clear lined out objectives. So we'll go through and we'll make sure that each of these are clearly explained. So vascular distensibility. So let's kind of read through his stuff and we'll jump back and forth. Okay. So what it actually is the ability to stretch in response to pressure. Another word that you might hear here is the word compliance. Did Dr. Tate mention that word compliance at all that you recall?
Not that I recall, but I also wasn't at lecture last week, so
okay.
I had a test.
So yeah, distensibility. If you've ever if you start thinking about medical type stuff, if you say like, oh, their stomach is distended, like it's bulging out, it's bigger, it's being, has more pressure against it. The same thing when we talk about the blood vessels, we talk about, blood pressure, all that kind of stuff that we're measuring. What we measure with blood pressure is how much force, how much pressure the blood is putting or pushing onto the blood vessels, specifically the arteries. And all of our vessels have something that's called compliance, or like the give that the blood vessels have. I kind of like to compare this to like a water balloon. Like if you have a brand new water balloon out of the package and it's all nice and neat, and you start filling it up with water, it's going to expand, and it's going to expand nicely. It's going to expand to the maximum size that it allows for, right? Have you ever, by chance, felt like left a rubber balloon out in the sun, or found one that's like a couple years old in the bottom, like in the back of a cupboard or something, and then tried to blow it up?
Yeah, it's kind of like it's really givey.
Yeah, it can be really, really givey, or as well, like the elastic can start to wear out. So think of like a pair of pants, or like a pair of basketball shorts that has the elastic around the waistband. When the pair of pants is new, you stretch and it snaps back really nicely. But as it gets used over and over and over and over and over again, the elastic gets kind of brittle, gets kind of stuck in whatever position that it's in, and it doesn't have that same, give and retract as it used to have, right?
Yeah.
Our blood vessels are very similar. Hey, Elizabeth, we got started a little bit late just because I was or reorganizing and figuring out stuff, so you're right on time.
Okay, cool.
So really when we talk about compliance of the vessels or that distensibility, we're saying, okay, how much give or like accepting of the pressure do our vessels have? Okay, because that's going to be directly correlate. It's going to directly affect what our blood pressure and stuff and is going to look like when we get down to that spot. So if we continue, so the ability to stretch in response to pressure, so how much pressure needs to be applied to stretch a vessel. We talk about normal blood pressure, that 120/80 is considered kind of our normal blood pressure. Technically less than 120/80 is normal. But as a person gets older, and we start talking about more geriatric senior age patients, their blood pressures tend to look more like kind of 130 to 140 over 85-ish or so, sometimes up to 90. And that's because their vessels don't have as much give. So you're having the same amount of blood into a smaller space, into a piece of elastic that doesn't stretch as far. And if it doesn't stretch as far and we just have the same amount of stuff in there, then the amount of pressure is going to go up, because pressure equals the amount of stuff times the amount of space for that stuff to be in. So if we have more stuff or less yeah, this equation isn't perfect, but if we have more stuff equals higher pressure, less space equals higher pressure. That equation isn't quite right. I don't remember how to fix it, how to make it look all pretty, but it's fine for our purposes now. Okay. So the elastic arteries, especially when we talk about arteries, remember arteries have that level of elastic. Artery anatomy. We look at our arteries and we have, for some multiple different layers, we have that elastic layer inside of it, that elastic lamina. There's multiple of them, as well as lots of muscle. So our arteries are built to be very stretchy, and they have all of that muscle to help move blood. So the arteries require relatively high pressure to cause this stretch. Again, just like we say, like 120 millimeters of mercury is a decent amount of pressure. The aorta is considered descendable. This just means that the aorta, has some of that give to it. Stretches during ventricular ejection. And see, this makes sense, because if we think about ventricular ejection, we're taking blood. So blood is leaving the ventricle and going into the aorta. And so we're increasing pressure because we're adding more stuff. Because we have more stuff, we increase the pressure, and that causes the aorta to expand, to have a little bit of give. And it recoils during the diastole thanks to that the elastic components of it inside of it. This is, I would say, kind of separate here, and this is just like an extra little tidbit that we'll talk about later, that the pulmonary arteries receive blood at a lower pressure. So if we think about our lungs, in order for air to go into our lungs, the way that works is our diaphragm contracts and pulls down, which creates a negative space. So here is somebody's chest right here, and we have lung, diaphragm right there. The diaphragm, when it contracts, we'll switch up the color, and when it contracts, the diaphragm, or when we breathe in, the diaphragm contracts and gets lower, which creates extra space down in here, but we don't have just random more air and stuff in our body. So what that does is it decreases the pressure that's inside of our lungs, and air rushes into our mouths, and our lungs expand. Okay? And so because our lungs are expanding with oxygen, and we have less pressure inside of the lungs than outside of our bodies, because we have to get air to go from a high pressure to a low pressure. So it goes from high pressure outside to low pressure into our lungs. We need a much lower pressure in our pulmonary arteries, because if that pressure was too much, the blood would just go straight into the lungs and leave the arteries. Maybe it would be a whole big old mess. And we'll talk more about that later on. So that's why this says higher distension than systemic arteries. So we talk about the pressure. How do we increase or decrease pressure? So to increase pressure, we add more stuff or we do less space. In order to decrease pressure, less stuff or more space equals lower pressure equals lower pressure. But because we're set with how much blood we're putting through there, we create more space. These pulmonary arteries are way more distendable or way more compliant. They're able to give a lot better in order to keep the pressure in the lungs lower.
That's an exam question, only for veins.
Does that component kind of the way that we're going so far, does this all make sense? Any questions or like confusion here?
Makes sense to me.
Elizabeth, are we okay?
Yeah.
Okay. Sweet. So here we have an equation. Anytime that we see an equation from here on out with blood flow stuff, make sure that you write it down somewhere. Okay. So this question, if you guys have a little document that you're taking notes on or something or whatever, right now is the time. Make sure that you write down this equation right there. Okay. Again, repeating the definitions. Veins are highly distensible. This is going to be another kind of test question, 8 times more distensible than arteries. Usually when there's a specific number, sometimes that likes to be a test question. So that one I would make sure I write down. The veins are going to store the blood that can be mobilized when needed. And veins are considered reservoir vessels. What do you think that means? Reservoir vessels.
They can hold more.
Yeah, like basically this is where the blood hangs out until it's really needed. So arteries, are really, really muscular, like we saw in this diagram. They have multiple layers of muscle, and that's to help them to squeeze and to push and to get the blood where it needs to go, because it has a whole bunch of, the nutrients and the oxygen and stuff that our body needs. So we need to have really good, quick control of it. The veins, on the other side of things, and remember, we work under the assumption of we're going from high pressure to low pressure. So the venous side of things has very, very low pressure so that blood continues to flow in that direction. So that means the veins need to be way more compliant. Because remember, we have the same amount of stuff going through, but we need more space to decrease. We need to decrease pressure. So we get more space to lower the pressure. How do we get more space? We allow the vessel to expand more to give us more space to drop the pressure.
My question on that is, so technically veins are highly dispensable. Dispensable,
yeah, that word.
But at the same time, is the force that they need to become more distensible greater than or less than an artery?
Less.
Okay.
Yeah, so it's kind of like if we I'll go back to the balloon example a little bit I was talking about a little bit earlier.
Sorry,
So,
I missed that.
No, you're good. I'll go over it. So balloons are also obviously elastic. So if you take a brand new fresh balloon out of the pack and blow it up, like you can blow it up, there's a little bit of resistance, and it can only blow up so big until it pops. If you take a balloon of the same size and same brand new, but before you blow into it, you stretch it out really good.
Okay.
Right? It's easier to blow up, and it can blow up bigger.
Okay.
So that's kind of a comparison between the two. Think of the veins are like a slightly larger, thinner balloon that's easier to blow up and to expand. It expands bigger. And the artery is more like a heavier elastic type balloon that takes a little bit more force, stronger air, stronger pushing to get it to expand and to blow up because it has those extra layers of muscle.
So it doesn't take as much pressure to stretch as an artery when compared. Yes, that makes
Correct.
sense.
Yeah. And so that's because they have less smooth muscle. So because the veins have less smooth muscle, they stretch more with less pressure or under lower pressure conditions. This little chart up here is really, really cool. And this is going to kind of be where a chunk of questions comes from. So if we look at these, right, the left ventricle, what's up with this? Why does the left ventricle go from almost 0 up to 120 and then back down and up again and back down and up again? What's up with that? What do we think is causing this up and down and up and down?
Systole, diastole.
Yeah, systole and diastole. So when the ventricle squeezes, right, it's increasing pressure. Pressure builds until it shoots out into the arteries or the aorta. And then here, systole, diastole in the aorta, you see it go up, down, up, down, up, down. And as further we get away from the heart, the further we get away from the heart, the less pressure we're going to get. That's why it's like if you take blood pressure, for example, if you take blood pressure at the arm, it's going to be different than if you take blood pressure at the ankle. The blood pressure at the ankle is going to be lower than at the arm, or at least it should be. And that's because the further we get away from the heart, in the sense of like the whole loop. So we have our heart right here. Our aorta comes off of the heart and goes off, and then branches into arteries, and then the arteries branch into arterioles, and then those branch more. They all branch until eventually they branch into the purple. They branch into the capillaries, and then from the capillaries, those enter the veins, and then they continue all the way back to the heart, going from capillaries to venules. Venules are the smaller ones, and then the venules turn into bigger veins until finally it gets into our vena cava, our big vein, our inferior or superior vena cava, and then those come and dump back into the heart. We can start to think ahead a little bit about disease-wise. What happens if, let's say, our heart starts to fail and like our left ventricle isn't doing its job as much as well, and so we start getting blood backing up in the heart. So we get more blood in the beginning of the heart, on the right side of the heart, and the right side has to work harder. If the muscles of the heart are working harder, what does that cause the muscles to do?
Hypertrophy.
If the muscles hypertrophy, was that going to give us more space on the inside or less space if the muscles are taking up more space?
Less.
Less. And if we have less space, what's going to happen to the pressure?
It's going to increase.
We get an increase in pressure, right? And that increase in pressure there at the heart increases all the way back. And we think about, trying to remember our anatomy a little bit, the vena cava, specifically the inferior vena cava, do we know what organ that inferior vena cava is coming from?
Like the lower limb?
Think organ-wise. So it's coming from all the different parts of the body, right? It's coming up into the inferior vena cava, it's coming up, all the venules, vessels are all kind of coming together. They actually all go into the blood filtration system. What filters out all of our toxins and does all kind of stuff is the liver. So it comes up into the liver and then kind of filters into the liver, and then the vessels all come back together and then they dump into the inferior vena cava. So if we get heart failure and we get buildup of pressure in the vena cava, that feeds back, increases pressure into the liver, and that's when we start getting liver issues due to heart failure. Everybody kind of follow our logic through there?
Mm-hmm. Yeah.
Yeah, so it's a whole, yeah, because it's a closed system. So if we have issues, especially like on the right side of that heart, that's where we start. So right-sided heart failure is often very closely related with liver issues, or with what's the name of it? I'm gonna look it up real quick. Liver. They call it either hepatic injury or like liver fibrosis, or later on you'll see this is more kind of try 5-ish in your lab dye class, where you'll see that you get the liver starts to get hurt, and so you get an elevation of liver enzymes in the blood, because when the liver gets hurt, it's going to release some of those enzymes stuff into the blood. So, but it's getting a little bit ahead of ourselves, but just kind of starting to send you down that path, because we're going to get to those kind of questions. Okay. So distensibility and then compliance. Technically different, but also almost the exact same. Honestly, like, the difference is just in the devil's in the details with this one. The only question, you want to know both of the formulas, but the only question he'll ask you that might be tricky is he'll give you like a straight definition, where vascular distensibility is the ability to stretch in response to pressure, versus compliance is how easy it is to stretch the blood vessel. So I don't think he'd be that mean to give you both of those and ask about that. I don't think he would. That's kind of what I could see is him having each of the different equations, but I don't think he'd be that mean. Okay, but vascular compliance, as I mentioned above, vascular compliance is kind of that give that the vessel has. Make sure that you write down this equation, because this equation is going to come back. Delta volume, so change in the volume over change in the pressure equals our vascular compliance. So arteries are less compliant than veins. Same thing as distensibility. So example, so adding volume to a vessel. So 10 milliliters of blood is added to a vessel. Pressure increases 10 millimeters of mercury. So 10 millimeters is added, so our change is 10 milliliters over 10 pressure our compliance is 1 milliliter per millimeter mercury, versus we add 10 milliliters, pressure increases by 20, and that gives us a compliance of 0.2. With people, we want a high compliance. High is good as far as compliance is.
Wouldn't that be a 0.5?
10, yeah, it would be. .5. Good catch. So we want a compliance. So a lot of times, most of the test questions that you're going to get, and one of the activities that he's going to have you do, is compare compliance. I think you do this in lab. Compare compliance. There's like questions where he has like a son versus a dad, where they have the same exact blood pressure, but then and they add the same amount of blood, but the pressure changes are different. So typically, we will see that older patients are less compliant in their vessels and just about everything else too. A little bit of joke there. Literally, they're less compliant in their vessels and tend to be less compliant with a whole lot of other stuff. So, looking at this again, this is just more reasons, again, why veins are more distensible and more compliant versus arteries. Any questions about compliance?
Good here.
Thank
Okay.
you.
This stuff is fairly straightforward if you get it explained straightforward. Okay. The vascular distensibility compliance continuing. So arteries stretch less than veins. A lot of this is repeat because the arteries have lower distensibility and compliance compared to the veins. Most of this is just repeat. 8 times more distensible, can hold more blood than arteries. They have 3 times the amount of blood. Small volume changes do not result in large changes in pressure. 24 times more compliant. This is another one that you're going to want to remember. This is another way he could test difference between compliance and distensibility. Veins are 8 times more distensible than arteries, and they're 24 times more compliant. That more than likely will be a little detail that he will like to test on. Most teachers do like to test on those kind of little details. As well, kind of this graph here, we look at sympathetic stimulation and sympathetic inhibition. So the nervous system stuff, the way that we control the size of the vessels, and we'll get into this more when we get like the neuro stuff, is through smooth muscle control. And smooth muscle, remember, which one has smooth muscle, has more smooth muscle, the veins or the arteries?
Arteries.
Arteries. So when our nervous system gets involved, we're going to be focusing on messing with the arteries. So we're going to either constrict or we're going to dilate, relax that smooth muscle in order to get the blood to go where we need it to go. The veins, did he go over vein anatomy with you guys?
We just did for blended this week.
Okay. So something super important. You see patients a lot of times, especially older patients who are not very mobile, who maybe have, heart conditions, liver issues, that kind of stuff. When you look at their legs, most of the time, their legs are really swollen, right? Has anybody seen that, noticed that?
Yeah, and they also have varicose
Yep.
veins.
Yep. And varicose veins. And that's because, so within the veins, this is the big part that I want you to remember. Arteries have muscles, and they can kind of contract and squeeze and pump the blood along. Veins just have these valves, these one-way valves is what they are. So These one-way valves, when they're normal, they allow blood to go up, to go continue in through them, and then if blood tries to come back, the valve closes, and the blood can't flow backwards. So if we think all of our vessels, right, they run through all of our muscles. And when we're active, what do our muscles do?
Contract.
They contract. They squeeze. So literally movement and moving, this is how, like when we exercise, this is how our cardiac output increases. So remember, the only way to get an increased cardiac output, to more blood out, is we have to get more blood in to the other side, to the beginning of the heart. And this is how it happens. When we activate more muscles, more blood, our muscles activate, they squeeze, and that pushes the blood back towards the heart faster, and we get more blood coming back to the heart, so more blood can leave the heart, so then we can continue to move and do what we have to do. Does all of that make sense?
Yes.
And this is exactly why patients, who have varicose veins, who have liver issues, who have heart issues, a lot of times like liver and heart issues tend to coincide with conditions like obesity, diabetes, all that kind of stuff, and movement limiting conditions. So, okay, and that's why we see here the sympathetic stimulation. Pressure goes way up in the arterial system. It doesn't have as much effect in the venous system. It goes up a little bit because there's less smooth muscle in the venous system. So a lot of our control is going to come from the arterial side of things. Okay, so the pressure volume curve, arterial circulation. So normal blood volume is about 700 milliliters. MAP, this stands for mean arterial pressure. The way that you find mean arterial pressure, make sure which equation. Does he have an equation that he likes? Nope. There's a couple. Let me pull them up.
We just had it on our test today.
Oh, really?
Yeah, because we are a week ahead of the traditional.
Gotcha. So these are, so right here, this is our, so we're going to have mean arterial pressure equals 2 times diastolic blood pressure plus systolic blood pressure divided by 3. And this is because the diastolic phase lasts longer than the systolic phase. So let me just, right there, mean arterial pressure. Uh-oh. Computer started to freeze. Okay, we're good. So mean arterial pressure equals 2 times diastolic blood pressure plus systolic blood pressure. All that divided by 3. You can also technically write it as mean arterial pressure equals diastolic blood pressure plus diastolic blood pressure plus systolic blood pressure divided by 3. Like that. Either of those are acceptable. So you'll see that sort of equation pop up. So the normal blood volume, 700 milliliters. When arterial blood volume drops below 400 milliliters, pressure falls to 0 again, because if we have less stuff inside of the vessel, less stuff means less pressure. Venous circulation, again, has a whole bunch more blood compared to the artery side. Average mean pressure is only 10 millimeters per mercury. And even with a change in several hundred milliliters, we only get a change of 3 to 5 millimeters of mercury. Make sure it's a change of several hundred milliliters. Change of pressure is only 3 to 5 millimeters of mercury. And again, that's due to that high compliance and distensibility, however you spell it. A lot of this, the nervous system stuff, if I'm not mistaken, there's going to be a whole separate PowerPoint just on nervous system interaction, correct? Exam 3. Local control blood flow. I feel like there is. We'll get there when we get there. But just like I said, the sympathetic nervous system stimulates the smooth muscle because there are there's more muscle in our arteries. That increases way more. We get less volume, which allows the transfer of blood among regions of the body. When we talk about local transfer and like overall like movement of blood, we'll talk more about kind of. I'm just going to introduce the idea here: local blood flow versus systemic blood flow. We'll talk about this more later on when we get to kind of like the actual blood flow stuff. But the idea behind this is what is happening locally can be different than what is happening with the body overall. So for example, like if we're doing bicep curl just on this one arm, all of these muscles here, these guys are getting activated because they're getting activated right here and they need all the extra nutrients, the extra oxygen. In the immediate area, the local area, we're going to get vasodilation. But in other parts of the body, systemically, overall, the other parts of our body that are not working, those ones are going to constrict, vasoconstrict, to allow for more blood to get to the bicep. So local versus systemic. We'll talk more about that a little bit later on, but that's a super key thing that teachers like to test on, and like the questions get really, really confusing if we don't go through there. Okay. Delayed compliance, stress relaxation. So increases in venous volume will increase venous pressure immediately. Under elevated volume, pressure is decreased rapidly. So the increase in venous volume. So when our volume increases, the venous smooth muscle relaxes to reduce tension on venous walls, results in a decrease in pressure. Stress relaxation, so delayed compliance, allows auto-regulation of blood pressure in the presence of blood volume changes. Decrease in venous volume, delayed compliance. I don't actually remember ever talking about delayed compliance. Let's see if I have something in my other notes. Oh, here we go. Okay. I don't ever remember getting tested on delayed compliance. The general idea of it is that when we get that increase in blood volume, the veins, for example, will slowly stretch instead of stretching really, really quickly. And just like the slow stretching of the muscle helps to relieve the pressure of the increased amount of blood. So we increase the volume, the fibers go until the blood passes through, and then we get more delayed compliance at the end, depending on what the situation is. It's over an extended period of time. Again, I don't remember ever getting questions about this, so I wouldn't worry too much about it. So that's a weird I probably know definition-wise, so I know this first line. And then essentially just that, hey, the veins relax when they get a bunch of blood put into them. Yeah, so increase in volume, smooth muscles relax to reduce tension on the venous walls, stress relaxation. So when you apply stress to something, stress to the walls of the vessels, they relax. Yeah, the auto regulation. Those are the key points that I'd hit. I'd remember those. Other than that, meh. Like I don't remember this like at all. So, I think, well, if Dr. Tate is anything like the previous teacher, the question that they'll probably ask is more along the lines of the bladder, of how the smooth muscle in the bladder is like the same when, as the bladder gets more and more full, because our bladder originally, when it's empty, it's really, really small. And then as you get more and more urine buildup, the bladder stretches until it's essentially full and signals that you have to go to the bathroom. So similar idea where you just, as you put more volume of stuff into something with smooth muscle, it naturally opens and relaxes. So a lot of words for a concept that's not super important in my mind. Okay, questions up to this point? Everybody doing okay?
So far, so good.
Okay. What is the arterial pulse? I feel like we already kind of covered this as well. Pulse pressure, this kind of stuff. We mentioned this before when we talked about the cardiac cycle. So pulse pressure is how much change in pressure you get from diastolic to systolic. Another equation, write this down. You will need this equation many times. All of this is just giving this exact stuff. Here's another equation for pulse pressure. Pulse pressure equals stroke volume divided by compliance. I'd write down those equations. All this other stuff is essentially stuff that we've already talked about. Factors that affect the arterial pulse pressure: normal arteriosclerosis. What is arteriosclerosis?
Plaque in the veins and arteries.
So plaque in the arteries. So if we have plaque buildup in the arteries, right, is that going to make the vessel move easier or make it more difficult for it to expand?
Harder to expand.
Yeah, so what happens to our compliance? Does our compliance go up or down?
Down.
Yeah, decreased compliance. Decrease in compliance. If we look at simple math, let's say our compliance originally is at 1, so stroke volume divided by 1, versus our stroke volume divided by 0.5. Dividing by a smaller number makes the overall number bigger, so pulse pressure goes up. And same thing, stroke volume, when we look at the stroke volume, again, we think about pressure. If we put more stuff, more blood into the space, pressure goes up. That makes sense why it goes up. So same thing here. Like if we look at pulse pressure, one reason could be arteriosclerosis is like a pathological reason. Another way that our pulse pressure could increase would be, let's say we're doing lifting exercises. When we're doing lifting exercises or exercising at all, typically our systolic pressure goes up. Diastolic. Let me make sure. Pretty sure it is. Yeah. This will come back later up in stuff. So diastolic, there's two types of exercise: cardio exercise versus lifting. lifting, diastolic and systolic tend to go up. Cardio, systolic goes up. Diastolic stays the same or goes a little down. This will come back up in lab. You'll talk about this in lab. But so doing stuff like cardio, where you increase your systolic blood pressure, can also increase pulse pressure because your compliance is staying the same. But when you exercise, your stroke volume goes way up. Dichrotic notch will still be present. I mentioned the dichrotic notch previously. Do you remember? I don't think I explained it super well. Do you guys remember what the dichrotic notch is?
Not at all.
Okay, so the heart is sitting in our chest, and most of the time we are vertical, and there's this thing called gravity. The arch of our aorta goes up, and then it comes down like this, right? So what happens is we're measuring the pressure inside of the aorta. So this chunk right here, right in through here, this is when during our systole, when we're actively pushing blood into it, it goes up, it goes up, it goes up. And then as soon as that valve snaps shut, think of it, we get kind of the valve snap shut and we get kind of almost like a little rocking motion. The gravity is going to pull the blood backwards, back towards the valve. So our heart squeezes, it pushes all the blood out, and then our valve closes and the blood almost kind of like, because of gravity, kind of drops back towards the heart where it hits the valve and then stays. That's what the dichrotic notch represents, is just that gravity is a thing. Does that make sense? Or do I need to explain it a different way?
No, that's good.
Okay. So test question you might get is, what causes the dichrotic notch? Typically, best answer is literally gravity. Or the full explanation of like, oh, the valve closes and the blood like comes back down due to gravitational pull, blah, 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 blah. Okay. And so these graphs, as we start to get into these are going to be super, super important test question type stuff and reasoning through why this happens. So aortic stenosis. What's aortic stenosis?
Narrowing in the aorta.
Specifically, either of the aorta. Most commonly, we talk about narrowing of the aortic valve, the actual valve that goes through. So if we have a smaller opening of the aortic valve, how's that going to affect the blood trying to flow through into the aorta?
Gonna make it harder.
Yeah, it makes it harder. So harder for blood to go from the heart to the aorta. So less blood goes per pump, aka decreased stroke volume. And we look back at our equation. If we decrease the stroke volume, what happens to pulse pressure?
Decreased.
Yep. So if we decrease stroke volume, we can even write example equations of pulse pressure. So here we go. So pulse pressure decreases whenever we get a decrease in stroke volume or an increase in compliance. We get an increase in pulse pressure whenever we increase stroke volume or decrease compliance. Eventually, later on down the road, you'll have a bunch of questions that are just like straight arrows, and it's super annoying. We'll tackle that bridge when we get there, though. This kind of stuff, though, this is one of the best ways to study all this stuff. Like if this goes down, what effects does it have? What effects are either causing it or what else could be going on? So I would write like decrease in stroke volume leads to decrease in pulse pressure. A decreased stroke volume, how would that affect the cardiac output?
Decrease it.
Yeah, decreased cardiac output and so on. Like anytime that you find something like whatever it affects, what other things it affects, I like to, it's really, really good to write those things out. Because when it comes test time, you'll know, okay, if this decreases or if this changes, what are all the other things that are going to change? And that's really, really good for testing type stuff. Here we have another one, patent ductus arteriosus. So this is typically in a newborn where we have essentially a connector. When we're in the womb, we actually skip the pulmonary vessels because there's no need, for the blood to circulate to our lungs. So because we're getting oxygen from the umbilical cord, not from our lungs. So the blood goes directly starts to enter the pulmonary trunk and just passes directly into the aorta. Sometimes when a baby is born, this doesn't, usually as soon as you're born, you take that first breath and this seals off. Sometimes it doesn't seal off. Most commonly, if you give a baby just a little dose of ibuprofen, a lot of times this will then seal off. Very rarely, occasionally, they do have to do surgery and close it off, though. So, so we do get a mild increase in systolic blood pressure and a decrease in diastolic, because remember we're getting backflow. Blood is going to go from high pressure to low pressure. Blood goes from high pressure to low pressure. Aorta is high pressure. Lungs are low pressure. Does that all check out?
Yep.
Yep. I would take, when you start making a study guide or start pulling information, pull each of these pictures, and you'll want to remember each of these, kind of what they do and why. Remember these graphs, because these will pop up a lot on tests. Aortic regurgitation. When we have aortic regurgitation, we can also start to throw in some extra stuff in here. So let's talk about what is aortic regurgitation.
When the blood flow, godless.
No, you're good. Go.
It's when the blood flow going through the aortic semilunar gets kicked back into the left ventricle.
Exactly. So we have backflow, excess backflow. When we get that excess backflow, so it's kind of like we push out 500 milliliters, we backflow 300 milliliters. So then 200 actually goes on to do what it needs to do. Our heart has to push out 500 milliliters each time to get the necessary 200 that it wants for the rest of the body with each heartbeat. So with this, if we're pushing out way more blood volume, right? The actual pushing out of the volume that's pushed out of the heart with each beat, what's that called? The volume of blood that's pushed out of the heart with each systole. What's the name of that?
Stroke volume?
Yeah, it's our stroke volume. So with aortic regurgitation, we get a massive stroke volume. And also, if we notice, we're missing the dicrotic arch. Why would we be missing the dicrotic arch?
Because of the backflow.
Exactly, because of the backflow. Because we're essentially, whereas before, the blood was kind of bouncing back and hitting the valve. Instead, now it just flows back it's just flowing directly back into the ventricle instead of continuing to move forward. So we lose the dicrotic notch, as well as because we don't have the blood staying inside of the aorta, it's backflowing, we lose some of that diastolic pressure as well. So we go way low, we go way up. So our stroke volume increases by a whole bunch. So our pulse pressure is going to increase a whole bunch as well. Here's our whole chart. This guy right here. Also, with aortic regurgitation, what other issues within the heart are we going to have with aortic regurgitation? After a long time, what's going to start to happen with the heart?
Left ventricle hypertrophy.
Good. What's that going to look like on an EKG? What sort of findings, like pertinent findings, would we have with left ventricular hypertrophy?
Bundle branch block.
So a bundle branch block is a slightly different thing. I don't believe they're related. But something that does happen with a bundle branch block and with hypertrophy is mean electrical axis deviation. So with left ventricular hypertrophy, we're going to have a left-sided deviation, right? What about the QRS complex? What are we going to notice about the QRS complex due to ventricular hypertrophy?
It's going to have a higher amplitude.
Yeah. What's our number? What's the number that we're looking for? What's the normal height of a Q wave or an R wave? Not a Q, an R. What's the normal height of an R wave in blocks and boxes?
I know. I'm pretty sure it's 1.5 millivolts, but I don't remember how many boxes it is.
So it's 1.5 big blocks, or I think it's 15 to 17 millivolts is so like 1.5 to 1.7 ish of the big blocks, or like something like that. 15 to 1. How many little blocks is normal R wave? Usually use 15 to 17, 15 to 20-ish millimeters. So 15 to 20, so 1.5 to 2 big blocks. I think that's the number of blocks. Sorry, guys. Let me double check my EKG stuff because each little thing is, yeah, it's 0.1 millivolt per box. Each box is also 1 millimeter. So 15 to 20 millimeters, 15 to 20 small blocks, or 3 to 4 big blocks, because there's 5 small blocks per big block. There we go. If it's more than that, then we're looking at a higher QRS amplitude. Okay. Sorry, my brain was not in EKG mode right now, but I'm trying to tie it back in, because these kind of questions, is Dr. Tate doing cumulative questions on each exam, or is it just the final?
I think just the final.
Okay, so this is a kind of question that might pop up where it's like, okay, you have aortic regurgitation. The patient has aortic regurgitation, has been dealing with it for like a year or so or something like that. What would you expect to see in the QRS complex? Or he'd show you an EKG with a high QRS complex and ask which of the following conditions could present with the following QRS complex, with the following EKG. And that would be aortic regurgitation, because our ventricles working so much harder. Okay. Pulse points. This isn't like super important. Ones that you'll really want to know is common carotid, brachial, radial, posterior tib, and dorsal pedis. Those are the most common ones to check, as well as that will be on questions. Brachial artery and radial artery are super important for taking blood pressure. Common carotid is important for auscultating. And these two are important for lower extremity exam when you're looking at checking out the lower extremity. So, and like we said as well, the further away you get from the heart, typically the pulses and the pressures will be different. This will be a question. Pulsus paradoxus. Pulsus paradoxus is that there's a variation in pulse pressure during respiration. So during inhalation, the pulmonary vessels stretch more. If they stretch more, then they get bigger, so pressure goes down. On expiration, we increase the thoracic cavity pressure, so we increase the amount of pressure, increase squeeze, blood pressure goes up. So inhalation, blood pressure down, expiration, blood pressure up. Just super slightly, but it's something to note. Typically, he'll ask a question of like which goes up, which goes down. Inhalation, blood pressure goes down. Expiration, blood pressure goes a little bit up. There's also heart rate. I don't remember heart rate, which one goes. I'm pretty sure heart rate increases with expiration. Does heart rate increase with expiration?
He definitely asked that on this last exam. I had no idea.
Okay. I was opposite what I said. So what happens to heart rate? On inhalation, heart rate increases. What happens during expiration? Heart rate decreases on expiration.
I could have sworn it was reversed.
Yeah, I'm pretty sure I got those wrong because I thought it was reversed.
I mean, I would look at it and I thought it was reversed as well. So I'm sure if we dove deep into it, we could figure out the exact specific reasons why. It's kind of above our pay grade though. So now we know. Okay. This I wouldn't worry too much about. Transmission of pressure pulses. When blood is ejected from the aorta, the flow of blood does not occur immediately. It has to overcome inertia first. This isn't like super testable material. Transmission of blood flow. I don't remember learning anything about wavefronts. Let me take a look if I ever did learn about wavefronts and I just don't remember. Oh yeah, I did at some point. I don't remember this at all. Well, let's look. So pressure rises in the aorta, overcoming the inertia. The wavefront distension spreads to the aorta. Greater compliance of a vessel, the slower the velocity. So when the heart ejects blood into the aorta, at first only the proximal portion of the aorta becomes distended. So the first part becomes distended because the inertia of the blood prevents sudden blood movement all the way to the periphery. Okay, so this in normal speak, when new blood pushes in, it takes time for that new blood to push along all the rest of the blood because physics. That's all you really need to know. And so you get these waves that go out, the push, 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 and that is actually what you feel as our pulse. Like if you feel your own carotid, you feel the pulse, pulse, pulse. That's each of these waves, the blood being pushed. So kind of pushed, push, push, push in chunks like that. That's the human version of saying that rather than the science version of saying that. Does that make sense?
Yes.
I like this example. Like a snake eating an egg. Okay, many eggs. I like that. Does Dr. Tate, is he a tester on like specific numbers? Does he like to throw in like, what are the specific numbers? Or does he usually not test on those?
I try to forget his tests after I take them.
Okay.
So.
Okay. Most professors don't. Like, these are super like, usually you want big ideas. So just understand, like, this is the big idea I'd remember.
I feel like sometimes he throws in like a couple because he likes to get things more detailed than he really needs to.
Yeah.
But
like the numbers that I would
not
remember
like...
from this whole thing, I'd remember the compliance stuff, like the stuff way in the beginning. That's like the veins are 8 times more distendable and 24 times more compliant. Like that'll be a test question where like the numbers are like, that are kind of important. But I wouldn't worry about like these specific velocity type things. Damping, the pressure wave reduces as it travels through the vasculature. Just like anything that's moving, the more that it moves, especially like something that's moving through like a pipe or this little tunnel that is a blood vessel, it takes energy. That energy is going to get dispersed from different forces, like the blood and stuff rubbing against the sides of the vessel. So that's going to be our resistance. So resistance times compliance equals damping. There's another equation to write down. Pulse transmission, there's another equation to write down. This is literally just explaining, hey, the further blood travels, the less aggressive wave there is. So that's why you feel carotid artery, big, strong pulse. You feel axillary artery, strong pulse. Feel brachial artery, little less pulse. Feel radial artery, even a little bit less pulse. You feel, compare femoral to popliteal to tibial to dorsal pedis. Go to each of those pulses. The further you get away, the softer the pulse is going to be because the blood has to travel further and it loses some of its momentum. Veins, all of these functions, we've already pretty much talked about all of these. A question that does come up very, very often is like sizing, like put these in order. So you want to know like aorta is the biggest, goes to arteries, goes to arterioles, goes to capillaries, which are the smallest, and the opposite direction. Venules, veins, vena cava. You'll want to know that order of size. Central venous pressure. Pressure in the vena cava near the right atrium equals the right atrial pressure. Factors that regulate right atrial pressure. Factors that regulate the right atrial pressure. The ability to pump blood from the right atrium and ventricle to the lungs. Yeah, all of this kind of stuff. There's typically a question about Frank-Starling mechanism. So the pressure in the vena cava. feel like that mechanism is typically mentioned later. This is Frank Starling mechanism that basically put more blood into the heart, get more blood out of the heart. That's Frank Starling. That's typically a test question. Central venous pressure. Again, central venous pressure is normally 0 millimeters per mercury. That's what we want it to be. We want it at 0. The normal right atrial pressure is around 0 millimeters of mercury. This is tested on heavily. They're like, what's the normal central venous pressure? All the time that gets asked. Right atrial pressure increases when a whole bunch of blood goes into it, again, because of pressure. And if you put more stuff inside of the same volume, atrial pressure goes up. Increased blood volume, increased venous tone, dilation of arterioles. This is going to be more kind of, we talk about local stuff. We'll talk more about that when we get into like the actual blood flow stuff. How much do we have left of this? Jeez. Sorry. Okay. Any questions up to this point?
Not so far.
Just a lot of material. Okay. Talking about resistance. Like I said, so resistance, the best way to explain kind of what resistance is, here's a blood vessel. Here's blood traveling through it. The blood that's right next to the walls, you can think of it like if it's dragging against the wall, there's like friction, and it's going to slow the blood down on the sides more than it slows down the blood in the middle. That's resistance. So you think the more resistance that there is, so the more so large veins have little resistance when distended because there's less blood in contact with the outside and a whole bunch more blood in the middle able to travel freely straight through. Here's more resistance stuff. A lot of this is just kind of, hey, read fun facts. Yeah. In the supine position, we get increased right atrial pressure. This is why people who have heart issues, like right-sided heart failure, if they lay flat on their back, they can't breathe as well. Their heart doesn't work as well because you increase the amount of pressure in the right side of that heart. So blood doesn't travel as well. So that's typically a test question they'll ask, like if somebody has congestive heart failure. I don't remember if it's in this class or other classes. Most comfortable position to sleep is inclined. Usually in a chair of some sort, like a recliner chair. That'll pop up quite a few times. The effects of high right atrial pressure. We already kind of talked about this. When right atrial pressure is greater than 0, blood backs up into venous circulation. When it gets up to 4 to 6, collapsed veins open up. Right atrial pressure increases further. Peripheral pressure must increase. Heart function must be substantially lowered. And during early heart failure, peripheral venous pressure is not noticeable. Yeah. So increase that pressure on that side. Blood can't get in as easily. Blood gets pushed the wrong direction. And that's what I was talking about when I talked about those issues with like the liver and all that kind of stuff. Intra-abdominal pressure on venous return. You have any of these things: pregnancy, tumors, obesity, ascites. Ascites is free fluid in the abdomen. That causes venous pressure to rise, and then yucky things happen. Pregnancy, this is why pregnant women get the swollen feet. They have increased venous pressure, so they have a harder time getting blood up. And then, of course, there's gravity. A lot of this is like itty-bitty detail type stuff. I wouldn't worry about a lot of these specifics. Yeah, I would just know, hey, gravity's a thing. I wouldn't know like these super specific things that he has. I doubt if he does have a question about this, it'll be like maybe one question. It's not worth memorizing all of that for one question. The venous pump. Hey, we already talked about this. When you have all the muscles, contraction of muscle forces the open next valve and causes blood to go all the way through those one-way valves. So when we walk versus standing, because walking, we're pumping all the venous blood back to the heart, versus standing, we're increasing because the blood is just sitting. And here are our valves, those varicose veins, because the valves get all messed up and the veins get all wiggly. The valves collapse under increased pressure, and you get the tortuous veins or turn into varicose veins. Blood reservoirs, already talked about all of this. Things we want to remember: total blood volume, 4.7 to 5 liters. That'll come back a ton of times. The veins are the reservoir for 60% of the blood. That's about main important stuff. And then other blood reservoirs, the spleen, specifically red pulp, has a bunch of red blood cells. The liver holds a bunch of blood. The large abdominal veins, the heart and the lungs, the venous plexus. I would know each of those, specifically the spleen. They like to ask questions about the spleen. Ooh, that took longer than I wanted. But how do we feel about chapter 15 now?
Not too bad.
Not too bad.
A little better than before?
Definitely.
Yeah.
For sure.
Considering that was all on my test today.
Yeah. Okay. This whole PowerPoint, this next PowerPoint, we'll fly through this really, really quick. This will be on, more than likely, just on lab exam. I would say watch out for this stuff on lab exam. I like the specifics of this, where the blood pressure cuff needs to be on the brachial artery. What are carot cough sounds? The clicks that you hear when you're listening for blood pressure, those are carot cough sounds. Please, I'm going to tell you right now, please always measure blood pressure using even numbers. I can't tell you the number of times that I've seen other students measure blood pressure, and it's like, oh, 123/75. No, we only measure blood pressure with even numbers.
I have to laugh at that one though, because of the fact that in the back of the rig, if you can catch it between numbers, we put the number in between. We love to piss off nurses with that.
Yeah, don't do that.
It's fun though. Or don't be crazy.
It might be fun, but you
Don't
will
do
literally
BiPAP.
get, if you say that on any practical in the future that involves blood pressure, which there are quite a few that involve blood pressure, you get an automatic 0.
Also, though, remember to if you're gonna do BiPAP, make sure you note that you took it BiPAP using, hey, I didn't use the stethoscope, I just waited till I couldn't feel the pulse anymore.
Yeah.
Also, don't piss off nurses. They run the hospital.
That's half the fun. Actually, no. Paramedics run the hospitals where I run work. 90% of the ER workers are paramedics.
Trying to think what other stuff he's gonna have in here. Oh, here's another equation for mean arterial pressure. Diastolic blood pressure plus 1/3 of pulse pressure. Gotta know those equations. Write those down.
My method. That was on the exam today. Heads up, you two.
Oh yeah, calculate mean arterial. Didn't you guys already have? Oh no, you guys have a different schedule. I think your guys' exams cover slightly different material.
They do. They're overlapped by a week.
Yeah, which is weird, but whatever. Yeah, those are the main things that are gonna be on there. Like, hey, what are karate cough sounds? What's a good definition for karate cough sounds? Let's see. With karate cough sounds. I hear my baby coming down. Give me 1 sec, you guys. Sounds appear in the cuff pressure between systolic and diastolic blood pressure because the underlying artery is collapsing due to the pressure from the cuff, and then reopening with each heartbeat. Give me 1 moment. Oh, I love that little bean. Okay. Yeah. Brachial artery, Krakow sounds, radial artery. What those are. Mean arterial pressure. Sweet. Please let the other one be super short. Gross. Blood flow. Let's see. How are we doing, guys? Are we good to keep going? Do we want to take a...
I'm exhausted, but I'm okay.
Let me see.
This would have been helpful last week for my exam today.
Pressure, circulation. A lot of this is overlap, and honestly, I don't know why he...
Quick question, actually, on the pressure, flow, and resistance.
Yeah.
Would the larger vessel have the least velocity?
Let Let me see. Where's the equation?
We actually had that as a question today.
Resistance to blood flow. This is Poiseuille's law. Geez, he's in.
Yep, right there. Yes, it would be faster.
Increasing the radius is an increase in blood flow. Okay, but there's a difference between blood flow and velocity. What was the question that you had?
It was which would have a slower velocity. It's inverse. So a larger diameter has a lower velocity and a smaller diameter has a higher velocity, if I remember correctly.
That's viscosity. Okay, I'm gonna go to my other slides because
Tate's slides put me to sleep. Tate's lectures put me to sleep.
Okay, local control of blood flow. Okay, I'm gonna go through this PowerPoint because this is gonna hit pretty much all the same things that other one is gonna hit, but I feel like it's gonna be a little bit. Actually, might need. It might be in the other PowerPoint as well. Resistance. Come on. Might be another set of slides. Okay, we'll mess with both of these then. I know it's in my other slides, but I have to find it. Whole circulatory system. Hopefully, we know what the function of the circulatory system is. It moves stuff. We deliver the oxygen and the glucose. We remove the waste, CO2, lactate. We have the pulmonary and then the systemic. Pulmonary is its own little thing just to the lungs. Systemic is throughout the entire body. The composition of the walls. I feel like in the maybe we did this backwards, but definitely should have had. This is one in the week he had this one as the last set of slides, but I think this one probably should have been the first set of slides because this gives us all of the a lot of this is going to be review stuff that we talked about from the previous PowerPoint. The different composition, the smooth muscle, the elastic tissue, the fibrous layer of connective tissue. We talked all about that, arteries versus veins and stuff. Big thing. This is always on test. What controls the blood flow? The arterioles control the blood flow. Capillaries are where all of the exchange occurs. Here's the veins, venules and veins. What they do. Arterioles and capillary beds. So we have meta-arterioles. She doesn't even have there it is. Meta-arterioles connect to the bypass channel. So essentially we have our arteriole has all this smooth muscle. It all comes across. We have these little guys called precapillary sphincters. If the tissue needs blood, these relax. So a bunch of capillaries are open and we can get blood. If the tissue does not need blood, these squeeze close, and all of these capillaries get squeezed close. So that way they don't have blood flowing through them because it doesn't need blood there. But it has these meta-arterioles, which act as bypass channels. So when all of these capillaries are closed, blood can still get across when it needs to, so it doesn't just back up in the tissue. A lot of words just to say that one little thing. Blood volume distribution. We already kind of talked about this. Big ones to remember. How much the veins hold. That's like the big one we need to remember. Blood flow velocity. Velocity equals the blood flow divided by the cross-sectional area. So this would be that question that you had. So increased vessel size equals decreased velocity. That's the answer to that question. The more it's dilated, the bigger it gets, the slower the blood is traveling through it.
Thank you, Drake.
As the total cross-section increases, blood flow velocity decreases. As arteries branch, total cross-sectional area increases. Another important thing to note, it's not just the dilation of single vessels, but let's say we have this coming down here, and then it branches into two, and then this branches into more, and then that branches into more. As we take our cross-sectional area of each one and keep going down, we give an increase in cross-sectional area because this one circle is smaller than slightly smaller multiple circles, add up all of the area, and this is bigger. And the reason why it slows down, so when blood reaches the capillaries, total cross-section area is the highest. This is a test question, guaranteed. It increases the time for exchange between blood and the tissues so that our blood is going to be the slowest in the capillaries. So our blood moves the slowest in the capillaries because that's where all of the exchange of stuff is happening, and we want it to be slow in that area. Pressures in circulation. We already talked all about this stuff earlier in the previous thing. Yeah, we definitely should have started with this PowerPoint, but because that would have had to explain a lot less in the first PowerPoint, but that is fine. Pressures in circulation. This will be super important for this week's microcirculation material. That's from microcirculation this week, right? Let's see, 3, 8, yeah. Microcirculation, capillary stuff. Microcirculation is all about capillary stuff. So 35 on the arterial side, 10 on the venous side, going from high pressure to low pressure. Blood pressure continues to decline all the way to the right atrium, where ideally it is 0 millimeters of mercury. These are all of the things that regulate blood flow, the contractility, constriction, dilation, all that kind of stuff. Pressure flow resistance, this is what I was drawing earlier, where along the walls you get more resistance. So blood on the outside of the vessel, towards the outside of the vessels, travels slower than the blood in the middle of the vessel. Flow, we should have the equation we start getting to a lot of equations. Some of these you'll use. Reynolds number, more than likely you won't use. You just need to know what it is. So the Reynolds number is the likelihood of turbulent blood flow. That's what you want to know for test. He probably, I don't think he would make you calculate. The ones he will like you to calculate, or at least understand to be able to calculate, are going to be some of these guys down here. Conductance, not to be confused with compliance. Conductance is different. This is the measure of blood flow given a certain pressure gradient, and it is inversely proportional to the resistance. So here's our equation for resistance versus flow. Which does he have? He doesn't have the... I guess these are what these next slides go. Each of these go through. I feel like this is a ton of words to describe these equations. I don't want to go through all of this stuff just because I don't think it's super beneficial. I'm just going to highlight some key things. Radius is the most important. This kind of thing will be a test question. The blood flow through a vessel is raised to the 4th power of vessel diameter. So what this is saying is the diameter, if you change the diameter or the radius a little bit, it really, really, really changes the overall blood flow. So like diameter is 1, that's 1 milliliter per minute. If you up it to 2, you're going to have 16, up it to 4, 256. Up it to the 4th power is typically the way that they'll do the question, that he'll answer the question. Changing in diameter or radius is the #1 way to change blood flow. And I touched on it earlier. Blood flow and blood velocity are 2 different things. And Kirsten, like you said, they're inversely related. So blood flow, I don't think he had a definition here of what blood flow is. No, he doesn't. Blood flow is counting the amount of liquid, how much stuff moves across a specific point in 1 minute. And velocity is just measuring the speed of that. So keep those 2 things separate. That'll be a ton of test questions. Blood flow is how much stuff is moving across a single point per minute versus blood velocity, how fast the blood is actually moving. The difference between these 2 is quite a bit of test questions, so make sure you understand that that is different from each other. Blood viscosity, how sticky the blood is. Basically, if you have more water, it flows better. Less water and more stuff, it's stickier. So like anemia, where you have less stuff, less blood cells, your blood's going to be super thin and go super quick. Polycythemia, poly meaning many, cyte meaning cell, emia meaning blood, so tons of red blood cells. Your blood's going to be way thicker and it's going to move slower. 9 times out of 10, one of these are a test question. Either anemia, like what happens to blood viscosity, or it'll say what happens to resistance to blood flow when you have a patient with anemia. So with anemia, viscosity goes down, we look at our equation. If viscosity goes down, top number gets smaller, resistance goes down. If viscosity goes up with polycythemia, viscosity goes up, resistance goes up. Blood flow autoregulation. Attempts to maintain constant blood flow. This is kind of what we talked about, where if you have more pressure being put on, the smooth muscle relaxes. Less pressure, it'll start to it'll go the opposite way and it'll contract to maintain a steady rate of flow. Yeah, we really should have done this PowerPoint first. Would have made things way easier. Anyway, temporary changes in blood flow. Sympathetic system, sympathetic nervous system, fight or flight, blood needs to move fast. Sympathetic control reduces the blood flow by constricting the blood vessels. With sympathetic activation, our fight or flight response, what parts of our body are going to need more blood and what parts of our body would need less blood? What do you guys think?
Vital organs are going to need more, I would think.
Which vital organs? Which ones do you think are going to need the blood?
Like your heart, lungs. That's probably your two major ones.
Yeah, remember it's fight or flight. So in order to fight or flee, what other parts of our body needs to have lots of blood to be able to do their thing?
Your limbs.
Our muscles, right? Those limbs, the muscles. So are we super concerned about digesting the 6 Hot Pockets that we just ate? When there's a bear, let's say we were walking through we're camping, we just had 6 Hot Pockets that we cooked in the fire, and suddenly we run into a bear. Is the first thing that we're thinking is, oh, my tummy is so full, I need to sit down and digest this? Or it's, holy, there's a bear, I need to run away from here.
Run from the bear.
Run from the bear. So sympathetic nervous system, we're going to give vasoconstriction in a lot of our gut, stomach, that whole area, and a lot of vasodilation in the lungs, in the muscles, in all of those different parts of the body that we need to get up and go. As well, sympathetic nervous system, our heart rate's going to increase, our pupils are going to dilate. All of the stuff to keep us alive is going to happen. Vessel length, more of these components. We talked about viscosity. We talked about radius. This is the most important part. Radius is always going to be the most important. Length remains fairly constant. Let's say we do change the length of a vessel. If we change the length of a vessel, what happens to resistance? We increase length up here. We increase the top number. That makes this whole thing bigger. So increase of length increases resistance. And if we go way back and we compare resistance to blood flow, this is going to be kind of the two, this way knowing these equations are super, super important. We're going to need to start to compare these kind of things. So flow is change in pressure over resistance. If we increase length, increasing length increases resistance, decreases blood flow. This is where those up and down arrows start to come in handy as we continue to combine all these different equations together and understand how they relate to each other. You will have questions just like this on your exam. We'll have several vessels like this. It'll show you their picture or just in words, and it will give you the length and the diameter, and it will ask, within all of these vessels, which of the following has the highest resistance or the lowest resistance or the highest blood flow or the highest velocity, that kind of stuff. It'll give you the information that you need to know as long as you know the equations. Series versus parallel blood flow. If you ever took physics, especially like physics 2, this is kind of that same thing, where if you have one tube connecting to another, you add them together, versus if it's running in parallel, it actually greatly decreases the amount of resistance. So parallel blood flow is better. You'll want to remember this equation. Series, you just add them all together. Parallel blood flow, it's 1 over each of the resistances. Literally this, either doing the calculation or just knowing the equation, is always a test question. 100% all the time. It's all the same words. Again, 100% all the time. Same is the test question. Okay. Yeah. Lots of stuff on parallel blood flow. So know what it is. That it's just splitting into multiple channels, and that it decreases overall resistance. That wasn't too bad. I know we just kind of flew through that because we spent a ton of time on the first chunk that we probably could have spent a lot less time on if we had done that one first, but it is what it is. Any burning questions, concerns, stuff going on? Y'all ready for me to shut up and go to bed?
I'm ready to go to bed. It's been a day.
I agree with that.
All right.
I would love to go to bed, but I've got about 2 hours of clinical imaging to do because I'm taking the 80% on my assignment from last week for lab because I overstressed physiology.